Hello, doctors, and welcome to Answer and When. Question number one: 45-year-old woman who is a known asthmatic comes for review. In the past 2 years, she has had around 6 exacerbations of asthma requiring oral steroids. Her current medication includes salbutamol 2 puffs, Prorinata, salmeterol 50 microgram twice daily, and beclometasone 200 microgram 1 puff twice daily. You note from the records that her BMI is 31. She's a non-smoker. Of course, she's a non-smoker. Asthmatic and smoking will kill the lungs, and has a good inhaler technique. What is the most appropriate next step in management? Is it to increase beclometasone to 200 microgram, 2 puffs twice daily, referral to a dietitian, add oral theophylline, add oral montelukast, or add inhaled tiotropium? First of all, they told us that she has a good inhaler technique, to know that there is no problem in the technique, because the problem in techniques is one of the most important causes of exacerbations of asthma. In fact, we should classify this patient. This patient is taking salbutamol and beclometasone. So she's taking SABA and low-dose inhaled corticosteroids. But how do we know that this is a low dose? In fact, low dose, which is less than 400 microgram budesonide or equivalent. And remember that 3 milligram of budesonide is equivalent to 10 milligram of prednisolone. So although she is taking salmeterol, there is something missed here, which is one of the key changes in step 3. Patients on SABA and low-dose corticosteroids whose asthma is not well controlled should be offered a leukotriene receptor antagonist, not a LABA. So the answer here is D. Add oral montelukast. Question number 2. A 38-year-old man is reviewed in the respiratory clinic complaining of episodic wheezing whilst playing rugby. There is no history of cough, atopy, or smoking. He is generally fit and well and has no past medical history of note. Clinical examination is unremarkable. Following history and examination, it is thought he has an intermediate probability of asthma. Which one of the following is the most appropriate next investigation? Is it A, spirometry and bronchodilator reversibility test? Is B, chest x-ray? C, histamine stimulation test? D, methacholine stimulation test? Or E, a trial of inhaled corticosteroids with FEV1 measurements before and after? In fact, in intermediate probability of asthma, BTS recommend to carry out further investigations, including an explicit trial of treatments for a specified period before confirming a diagnosis and establishing maintenance treatment. Spirometry is the preferred initial test. Treatment should be partly guided by the FEV1 to FVC ratio. A ratio of less than 0.7 is suggestive of asthma. Then we consider a trial of treatment. A ratio of more than 0.7, further investigation, or consider referral. The answer here is A, spirometry and bronchodilator reversibility test. And as a golden note, intermediate probability of asthma, do spirometry is the first line investigation. In low probability of asthma, an alternative diagnosis should be sought. Further investigations and referral to a spirometry specialist should be considered. In high probability of asthma, patient has many symptoms which make a diagnosis of asthma more likely. then the BTS recommend that we start a trial of treatment. A good response is considered a positive test of reversibility. Question number 3. We review a 27-year-old woman in the emergency department who has been admitted with an acute exacerbation of her asthma. Which one of the following features is most likely to indicate a life-threatening attack? Is it A. Failure to improve after nebulized salbutamol 5 mg? Or B. Cannot complete sentences? C. Oxygen saturation of 94% on room air? D. Peak flow of 30% best of predicted? Or E. Respiratory rate of 42 per minute? In fact, all of the following are features of life-threatening acute severe asthma. PEFR less than 33% of best or predicted. Oxygen saturation less than 92%. PA2 less than 8. And a normal PaCO2, a silent chest, cyanosis, or feeble respiratory effort, a bradycardia, dysrhythmia, or hypotension, exhaustion, confusion, or coma. These features are the features of life-threatening asthma. So the answer here is D. In fact, when the respiratory rate is more than 25, we consider it a severe feature, not a life-threatening. Cannot complete sentences also considered as severe. However, a silent chest is the life-threatening feature. Question number 4. A 43-year-old woman with a history of poorly controlled asthma is reviewed in the chest clinic. Tests showed an eosinophilia associated with a raised IgE level. Given the likely diagnosis of allergic bronchopulmonary aspergillosis, what is the most appropriate treatment to control his symptoms? In fact, prednisolone is the only correct answer between the options. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. With SSSM, you're always in a safe zone and you're always the winner.